Good morning, everybody. Before Dr. Sharkey introduces Dr. Sandoval, I just want to remind you that we have the January through May evaluation for Grand Rounds. There's paper copies outside of the room if you want it, and a reminder, sent out an email last week. We'll send out another one. It'll be open through this Wednesday, the 24th. And also, please make sure to stop by the exhibits and say thank you to our supporters for Grand Rounds that help us make this happen. So with that.
This morning, it's my privilege to introduce Yader Sandoval to everyone who already know him anyway. Yader has distinguished himself with his performance with us unquestionably. This is his swan song, right? Your last Grand Rounds as a fellow, and Yader will be going to join the Mayo Clinic this summer. Yader had his medical school education in San Jose, Costa Rica, and then came to Hennepin County Medical Center where he did his internship and residency. He distinguished himself at that institution by getting the Morris Davidman Teaching Award. That's a very prestigious award. He then went on and did his cardiology fellowship through the combined fellowship with MHI and Hennepin, and he was awarded a Young Investigator finalist last year at the American College of Cardiology in Chicago. I listened to his presentation. He was getting questions from all of the experts around the world in troponin, and he answered them with adeptness. So he was really did a great job. Yader has nearly 40 publications in peer-reviewed journals already in his career, including The Lancet and the JACC. He has done many book reviews and many book chapters. He is a reviewer for many of the journals, and he's highly respected in the field of troponin, which I find interesting since he's an interventional cardiologist. So figure that out someday. But Yader, I look forward to listening to your presentation. We're sure going to miss you around here. So.
Well, thank you, Dr. Sharkey, for those very kind words. It's really a pleasure for me to be here. Hopefully, not for the last time. It was around a year ago or so that I think it was January of last year that we talked primarily about cardiac troponin, which is certainly a passion of mine. But the reason I had to familiarize and learn about cardiac troponin was because I had a passion about understanding myocardial injury and infarction, and these two issues are tied directly. So today, rather than, well, certainly we'll focus a little bit on some of the recent updates and troponins, particularly because the FDA just cleared earlier this year in January high sensitivity assays in the United States. I do wanted to focus most of the time rather on understanding the disease process of myocardial injury and infarction, a journey that I embarked on probably around 6 years or so ago, a little bit more. And I've collaborated for quite a while with Fred Apple from the laboratory side, Steve Smith from the emergency, and so on. And we've done a number of studies that I wanted to share what we've learned over time. This is the framework of what I have planned here for the next 40-45 minutes, with hopefully having some time for discussion. I'll have a little bit of a rationale and historical background of how come where we are right now. And as I said, I wanted to provide a little bit more emphasis and discussion on the disease process, nomenclature, and outcomes of both infarction and injury, certainly with a focus on type 2 myocardial infarction, which has been a matter that has received quite a bit of attention in recent times. And lastly, particularly because I think it's timely, because of the recent FDA clearance for clinical use, I wanted to provide also some discussion on high sensitivity assays in relation to the diagnostic of myocardial infarction and injury. So why are we talking about this? Well, I think it's well known that the evaluation of patients with suspected myocardial ischemia is nationwide, worldwide healthcare problem. It overcrowds emergency departments and emergency and observation units worldwide. If you think just about patients with chest pain, and this is data from a number of years ago, there's more than 8 million patients that present each year to the emergency departments with chest pain that need to be evaluated to whether they have myocardial infarction or not. And if you think just solely about cardiac biomarker testing, because certainly there are chest pain equivalents or a number of other symptoms that may have atypical MI presentations, this is around 17% of all emergency department visits, which in a recent analysis by McCollum and JAMA Internal Medicine, it's around 29 million over a 2-year interval period. So this is a problem of a huge magnitude, and this is the reason, you know, some of us have had an interest in this topic. But from a clinical aspect, the reason why we're talking about this is because we're trying to assess risk. We're trying to identify patients that are at very, very low risk, in whom hopefully we can avoid unnecessary procedures, keeping them in the hospital if they don't need to, and hopefully send them home as soon as we can in a safe fashion. But by the same token, we're also trying to identify, tease out all this bunch that I mentioned, those who are truly at high risk that need to have further diagnostic and or therapeutic interventions. And that is the job, the task at hand. But in order to understand how we got to where we are now, as I said, I wanted to provide a little bit of a historical perspective, and I think we need to go a little bit back in time. And if you query the literature, the first report ever of coronary thrombosis is in 1878 by a German physician, Adam Hammer, who actually spent some time in the United States in St. Louis and then went back to Europe. And he encountered a patient, actually reached out by a colleague to evaluate a patient who had a clinical constellation of symptoms and signs that led him at the time, and I'm going to quote him, that he thought to himself that, that only the sudden, progressively increasing disturbance of the nutrition of the heart could explain the symptoms that this patient had, and he thought to himself that part of the differential diagnosis, this could only be due to a thrombotic occlusion of at least one coronary artery. I think this makes you pause and be amazed that in 1878, without ECGs, echocardiograms, none of the fancy tools we use today, this was what this physician thought at the time. However, at this point, as I said, there were no such diagnostic tools, and he ultimately performed a pathologic examination after the patient passed away. And to his amazement, indeed, he was true. The patient had coronary thrombosis. This is the first report of coronary thrombosis in the literature. However, a number of years passed until probably the next landmark publication. Certainly, there were a number of investigations, but the next landmark investigation is this one by James Herrick, which many of you may be familiar with, entitled Clinical Features of Sudden Obstruction of the Coronary Arteries. And the reason this is a landmark publication is because you may wonder how come it's not until the early 1900s that we develop an interest in coronary thrombosis. And the reason is because prior to this landmark publication by Herrick, there was this long misconception that having an occlusion of one of your coronary arteries was a fatal event. So that therefore, you were not expected to see these patients in clinic or in the hospital because these patients were dead. So Herrick and many others around this time came with a number of studies showing that clinically there were patients that had obstruction of the coronary arteries, and that you were encountering them in your day-to-day practice. But there was a misconception around that time. This is the reason this is an important landmark publication. And the reason I wanted to provide that historical perspective is because, as you at least saw from those couple of selected studies that I showed, the titles and the nomenclature that was used was that of coronary thrombosis. However, day to day, we do not refer to it as this way. We ended up using the term of acute myocardial infarction. And you may wonder how come was it that we ended up calling the syndrome acute myocardial infarction rather than focus on coronary thrombosis. And with that in mind, I think you will also need to go back in time and look at also some of the early publications from the early 1900s. This is one of the main ones from 1939 in JAMA by Friedberg. And this is entitled Acute Myocardial Infarction Not Due to Coronary Artery Occlusion, which is a fascinating study if you have the time to read, in which essentially they looked at a number of individuals now on pathologic examination that have presented with a number of clinical conditions, but who were on pathologic examination found to have myocardial changes that were completely indistinguishable, unequivocally, from those that you saw in coronary thrombosis. And they had areas of necrosis due to ischemia, thought to be secondary to inadequate coronary blood supply. However, these patients did not have coronary thrombosis. And again, this is 1939. And when you look at this, at the number of adjudicated diagnoses of why these patients ended up having myocardial infarction, it is interesting to see some of the etiologies. They had severe calcific aortic stenosis. They had severe acute anemia. They had malignant hypertension. And this will ring a bell with some of what we'll talk now in more the contemporary nomenclature, but even back in 1939, clinicians embraced the concept that you could have large areas of myocardial infarction and necrosis in the absence of coronary thrombosis. Certainly a number of other studies came about, and this is just in 1979, just for the purposes of illustration. There were other documents by the World Health Organization that were released around the time, but in the 60s, 70s or so, finally the WHO organization came out and said, let's define the clinical syndrome of acute myocardial infarction, and that was defined by history, ECG, and serum enzymes around the time. However, as you very well know from any aspect of medicine, it is an evolving issue. And throughout time, a number of other diagnostic modalities came about, which in addition to ECG and pathology, including newer, more sensitive chemistry assays from CKMB to troponin, and now more recently to high sensitivity troponin, which have transformed our understanding of myocardial injury and infarction, as well as various imaging modalities, both invasive and non-invasive, from coronary angiography, intravascular ultrasound, OCT, echocardiography, cardiac MRI, CT, and so on. And as all of these modalities came about, physicians, researchers, and trialists were faced with the task of trying to redefine myocardial infarction at the go, because we had new tools to assess the myocardium. And what happened, and I'll show on the next slide, but it was something that was embraced by many leaders in the field probably around a couple of decades ago, was that trials were being performed. And for example, you would look at one same therapy, but you would have quite opposite trial results despite assessing the same therapy. And what many of the leaders came to realize was that the problem was that MI was being defined in a different way. So actually, I personally had this issue with a meta-analysis that we worked on a number of years ago on completeness of revascularization of PCI versus CABG. And this included assessing thousands of abstracts and research studies over several decades. And interestingly, it ultimately got accepted and published, but in the review process, one of the reviewers said, you know, this is a number of studies over time, can you provide definitions of myocardial infarction? And indeed, we did that, but there were over 30 definitions of myocardial infarction. Some included ECG, other imaging, different cardiac biomarker assays, different thresholds. So you have to understand that around a couple of decades ago or so, and this has been a continuous evolving even until now, there was an evolving definition of what we embrace as the clinical syndrome of myocardial infarction. Because of those challenges, in the year 2000, some of the leaders in the field sat together and said, like, there's much heterogeneity in how we're defining myocardial infarction. So let's try to come with a group of leaders from different backgrounds and disciplines, including laboratorians, chemists, interventional cardiologists, non-invasive, from all over, and let's sit together and come up with a contemporary definition of what constitutes myocardial infarction. And the first definition was published in the year 2000 with a couple of iterations in the year 2007 and 2012. And what you need to embrace about the latter two is that they introduce a novel concept of a 5 MI subtype classification, type 1 to 5, of which the first two have received most of the attention, and we'll be talking about those today. But this is a little bit of the history of that nomenclature. The way I see it is that the universal definition of myocardial infarction truly, in a way, helped push the field forward in two ways. One, in making us think further about the disease process, about the mechanisms that can contribute to injury and infarction, and also reassess the nomenclature. and also about diagnostics, about what were the thresholds that were being used to call injury and infarction, and by the same token, the way we were performing rule-in and rule-out strategies for patients that were presenting to the emergency department with symptoms suspicious for myocardial ischemia. I'll start first off with the disease process. And when we see patients that have cardiac troponin increases above the 99th percentile, practically speaking, except for a few exceptions, this correlates to cell death. And the term to use, which I truly want to emphasize, is that the term to use is myocardial injury. Particularly, I think, from the cardiology realm. I realize that other terms are used outside cardiology, but even within cardiologists I've seen. But all these other terms, troponin leak, troponinitis, troponinemia, and even myonecrosis, do not really correlate to what's occurring at the biochemical and molecular pathways. And I'll talk a little bit particularly about the term myonecrosis, but the term is cardiac injury. And the reason I wanted to talk a little bit about the necrosis is because particularly when you think about how cells die, it's a busy slide, but I just focus on the three spots here in the three boxes at the bottom. It's really the three ways that cells die are through either apoptosis, topically associated cell death, or necrosis. When you think about the mechanisms of cell death in heart disease, certainly a vast majority are due to necrosis, but certainly there's also a number of cells that are dying because of apoptosis. And therefore, again, probably the best term to encompass insult is myocardial or cardiac injury. And timely, in a way, for me, for this presentation, one of the best basic science studies was just recently published this year in the New Jack Journal, the Basic Translational Science. Really a fascinating study if you have the time to look at it. They did a porcine model of ischemia. And the reason this was actually pretty neat and contemporary is because they were trying to assess, first, examine why there was troponin increases, and two, trying to assess that just with brief episodes of ischemia, because many of the models that had been performed in the past were with more prolonged episodes of ischemia, such as 30 minutes, and had other biomarkers. But this probably provided some insight into some of the contemporary challenges that we face today. So just to walk you through it, essentially what they took various porcine models. They performed ischemia for around 10 minutes, just brief episodes of ischemia by putting up a balloon in the left anterior descending artery. Then they provided reperfusion, and then they measured serial cardiac troponin measurements. And after performing serial cardiac troponin measurements, as shown here, they indeed identified that there was a marked increase in cardiac troponin measurements. However, then on pathologic examination, they came to identify that there was no evidence of necrosis, but rather that the main mechanism was apoptosis, which is truly fascinating and also further promotes that the right term to use is cardiac injury, which probably encompasses everything that's happening. And this really brings up to light and confirms a little bit of what we see every day in practice, which what we see every day in practice when we're getting consults or seeing some of these patients is that there are individuals in clinical practice that have just very brief episodes of myocardial ischemia, such as due to tachycardia arrhythmias or heart failure and others that can indeed have cardiac injury. It is, however, important to emphasize that the process of cardiac troponin elevation and injury does not equate myocardial infarction, and I think all of us embrace that. But in order to have the clinical syndrome of myocardial infarction, you need to have the clinical evidence of acute myocardial ischemia. What is that? That is definite symptoms, chest pain, or an equivalent such as shortness of breath, ischemic ECG changes, regional wall motion abnormalities, objective evidence of ischemia. And when that is coupled with a rise or fall in cardiac troponin, that is when a subset of patients with myocardial injury would have then myocardial infarction, something that, again, I think we embrace, but it's important to emphasize. And what the 2007 and 2012 latest definitions of myocardial infarction came to define, as I've briefly introduced at the beginning, is that, again, this has been well known since the early 1900s, as showed earlier as well, is that This is a clinical syndrome of myocardial infarction that can occur for various mechanisms, not exclusive of coronary thrombosis and atherothrombosis. So there's type 1 myocardial infarction, which is the typical MI that we're all familiar about, but there's also myocardial infarction type 2 that can occur in the absence of atherothrombosis. This is elegantly shown by the consensus document task force illustrations that, just to emphasize, refer to type 1 myocardial infarction as that is rupture plaque with thrombus, the bread and butter myocardial infarction that we see in clinical practice and for which we have robust strategies and evidence-based treatments. But however, type 2 myocardial infarction refers, for example, to 20, 30-year-old women coming to the emergency department with chest pain and ECG changes when angiography is then found to have vasospasm without atherothrombosis. Type 2 MI can be a patient from the Optimist Clinic who has severe multivessel, severe coronary artery disease that is unrevascularized, who has now severe anemia and presents with a hemoglobin of 4. So these are the patients that indeed may have the clinical syndrome of myocardial infarction without having objective evidence of coronary thrombosis. And a way to clinically approach this patient, I think, is just to have a checklist and think about how myocardial oxygen consumption occurs. And if you think about myocardial oxygen consumption and supply-demand and how supply-demand mismatch occurs, I think if any time you see any of these patients that have cardiac troponin increases and the mechanism isn't clear, you can just do a checklist and think about, is there an abnormality in heart rate? Is there marked tachyarrhythmias, arrhythmias? And there is contractility altered in any sort of way? Is there marked hypertension or hypotension? Is supply affected in any sort of way? Is there, for example, carbon monoxide poisoning or marked hypoxia? Is there marked anemia? And certainly, is there abnormalities in coronary blood flow, which ultimately would be defined in the cardiac catheterization laboratory and angiography, such as spasm, embolism, or endothelial dysfunction. And if you do a systematic approach to patients in this sort of way, you will come to realize that many of the patients that we thought had so-called myocardial injury due to supply-demand mismatch, sometimes you come to realize that they had really no major supply-demand mismatch, and that therefore, I would caution you not to call those type 2 myocardial infarctions. By the same token, you may come to think that a patient that had atherothrombosis then has one of these ones that are clearly abnormal, and then you would come to realize that maybe indeed he has MI in the absence of atherothrombosis. So we've looked at this in contemporary databases in Minneapolis, and if you think about the large proportion of patients that have cardiac troponin increases above the 99th percentile, and this, of course, is certainly an illustration that is dependent of how you use the test. But if you think about how we use it in the emergency departments of the United States, you can follow what I try to illustrate, and I think you will embrace it because it is probably reflective of what we see in the consults on primary services. And it is that of all the patients that have cardiac troponin increases above the 99th percentile, it is ultimately only a fraction of these patients, around 10 to 15%, that are ultimately deemed to have injury due to atherothrombosis or type 1 myocardial infarction. So therefore, we're faced with the daunting task of trying to understand why is it that all these other patients have injury and whether a proportion of these ones have type 2 myocardial infarction. We've actually looked at this. This is a paper that we were able to publish in Geography a number of years ago, that and it's an updated slide with more recent studies, but that essentially shows that the incidence, the rate of type 2 myocardial infarction is quite heterogeneous in the literature. You may wonder why that is. That is quite a wide range of incidence. And the reality is that it's multifactorial. Even though this consensus documents introduced this concept of type 2 myocardial infarction, there was never ever any clear definition, which has led to some degree of ambiguity in how we define the condition and how this is adjudicated. Studies have looked at different populations, and there's been different assays and cutoffs utilized in different studies. So just to further illustrate this, for example, here's the study by Bonacca. This is from the TIMI group. In 2013, they're assessing one cardiac biomarker assay. But if you go into the study and dig in detail the methods, they're looking just at individuals that have chest pain exclusively for over 10 minutes. And part of the exclusion criteria was that there was no other acute illnesses. So then people come and say, oh, type 2, it's just 10% of the population. But the study had a lot of selection bias towards those that had true acute coronary syndromes of type 1 myocardial infarctions. Contrast that with some of the work that we've done that we've examined the rate of type 1 and type 2 myocardial infarction in all comers undergoing cardiac troponin measurements in the United States emergency department groups, and you then come to realize that type 2 myocardial infarction actually constitutes the vast amount of myocardial infarctions that are seen in clinical practice. And again, when you think about the broad cohort, not the selection that we, for example, see in the cath lab. The other issue, as I said, is definition. There was never a clear definition, nor I'm sure that there were other because again, this is a clinical syndrome. But yet there's been a couple of approaches of how type 2 myocardial infarction has been defined. One way, which I think is the practical way that we use as clinicians, is to use broad diagnostic criteria, which essentially brings back to that algorithmic slide of how to assess patients with potential supply-demand mismatch, in which is you have clinicians or adjudicators look at the clinical context, see if there's any objective evidence of or documentation of a supply-demand mismatch, and if you think that that is happening in the absence of clear atherothrombosis, then you would call this type 2 myocardial infarction without applying any strict parameters. And I think that's what happens in most studies as well as happens in real life, right? You see a patient, had some acute depression, but had a marked anemia of 5. You're saying, I think this is probably the supply-demand ischemia. You're not using a particular threshold. However, a number of investigators and now a number of studies have come about that have supported the use of strict diagnostic criteria as shown on the left. And if you do that approach, you can see that even though they're using very strict criteria, the incidence of type 2 myocardial infarction is around 26%. This approach has advantages and disadvantages. The advantage is that, of course, it homogenizes and makes more reproducible research. However, it has limitations because it does not apply to everybody. It's very different, a 25-year-old healthy woman that comes with tachydysrhythmia to an 82-year-old gentleman with severe multivascular revascular disease who comes with SVT for 20 minutes. But as you can see, an approach that has been proposed has been, for example, that in order for you to call as a clinician supply-demand mismatch, that you would need to have SVT for 20 minutes, or would need to have bradyarrhythmia requiring atropine or pacing. So they have proposed certain specific criteria, particularly to try to better tease out injury from myocardial infarction. The mechanisms have been also examined, and if you think about the mechanisms that contribute to supply-demand myocardial infarction in the absence of atherothrombosis, Salve and al. Looked at this, and the main mechanisms are anemia, respiratory failure, and SVT. However, I do point out that if you add those that have tachydysrhythmia such as SVT and VT, this corresponds as essentially the main trigger of what is deemed to be the mechanisms behind type 2 myocardial infarction in nearly a third of patients, data that we corroborated in a U.S. cohort a couple of years ago, in which we also identified that around 36% that was the main mechanism leading to type 2 myocardial infarction. And you may wonder, okay, so this is frequent. I feel I see a bunch of these patients every day in practice. Does it matter? Well, it does. Our group was actually one of the earliest ones to identify that patients that had injury, as well as those that had type 2 myocardial infarction, had a much worse prognosis. We looked at this in the European Heart Journal a number of years ago, and we, in comparison to those that have normal troponin or absence of cell death, those that had injury, as well as those that have type 2 myocardial infarction, had a significant increase in mortality at 180 days. Findings that were also shown to be the fact on adjusted models on hazard ratios. However, a limitation of our analysis, as well as others, is that you may very well argue, well, these patients have a number of other comorbidities. They may be dying for a number of other conditions, not exclusively cardiac. To our fortune, and to better understand the mechanisms of death in these patients, a group from Mass General, led by Jim Janussi and Hannah Gagin, looked at this and published recently in Circulation from the Casablanca study. This is a catheter sample blood archive in cardiovascular disease, which was a robust analysis going to over 3 years follow-up, and they had very detailed follow-up and adjudication methods, and they compared patients with type 2 myocardial infarction versus those without. And patients with type 2 myocardial infarction have an increase in MACE, all-cause death, cardiovascular death, heart failure, and arrhythmia. And the robust follow-up and number of events that they had allowed them to look at this in more detail on adjusted models. And indeed, they confirmed that the incident diagnosis of type 2 myocardial infarction was strong predictors not only of all-cause death, but also of subsequent MACE and cardiovascular death. So again, an important publication from this year in Circulation. So now I've mentioned over this beginning of the talk that type 2 myocardial infarction is quite frequent in our practice. I think we can probably acknowledge that, and also too that it's associated with worse outcomes. However, no guidelines exist to address its management, probably partly because it's a heterogeneous conditions that trigger this, but there's absolutely no guidelines, strategies, protocols in place to guide how we manage these patients. And this absence of guidance results in variable management, something that in a way I've been in a position as fellow to embrace this, because as you work with different people, you can embrace how one individual would say this is a leak, nothing of magnitude, and no further workup occurs, whereas on the other hand, someone that appreciates the magnitude of the significance performs further workup or search for myocardial ischemia and other factors. So you can see that this truly results in variable management. From a practical perspective, which I think is somewhat intuitive, is that the recommendation has been to treat the underlying etiology, which of course makes sense. If you have severe anemia and that's contributing to ischemia, please treat the anemia. But another important factor that I want to bring to your attention is that there is a significant proportion of patients that have supply-demand myocardial mismatch, that have concomitant coronary artery disease, and that the process of coronary artery disease should still invoke following those guidelines. And therefore, you should still consider in these patients therapies as you usually did, and put these patients on aspirin and statins and consider myocardial ischemia assessment. And a number of studies have looked at that. We summarized earlier this year. I had the privilege of working with Kristen Tiggeson, who is the chairman of the Universal Definition of MI, and we examined the studies that had looked at the prevalence of coronary artery disease among patients with type 2 myocardial infarction. Certainly, there's some selection bias because this is observational, and this is only a number of patients that are being referred for in geography. But when you look at this, if you look at contemporary registries such as this one from the Sweetheart, that this is thousands of patients, you come to realize that around 50% of patients with type 2 myocardial infarction have coronary artery disease. But therefore, however, when you look at the data, a number of these patients at discharge are not even sent home on aspirin, statins. They have no follow-up strategies planned. And in cardiology, we often don't have protocols in place to see them in clinic or nothing else, since they do not have atherothrombosis. Some people, in order to further tease out the mechanisms of myocardial infarction, have proposed a new term. This was pushed by investigators from Australia, who have come with the term of MINOCA, of MI with no obstructive coronary artery disease, which I think I appreciate the efforts, because their ultimate goal is for us to not dismiss patients that have the clinical syndrome of myocardial infarction in the absence of obstructive coronary artery disease. And if you define it that way, it corresponds to around 5 to 10% of all MIs, or around 8%. There's a very robust analysis from the Sweetheart registry. There's thousands of patients, and again, in which they were around 8%. But ultimately, even though this classification has some value, ultimately at the end, you're still faced with the daunting task of differentiating between type 1 and type 2. And if you look at the Sweetheart registry analysis, the vast majority were still due to what was thought to be atherothrombosis. There were still a proportion of them being due to type 2 myocardial infarction. So again, this is a useful classification, a novel one. However, it doesn't really address the pathophysiology, the underlying pathophysiology, nor has therapeutic implications. So with that, also in this recent document that I had the privilege of working with the chairman, Dr. Tiggeson, we provided a framework of how to assess myocardial injury in practice. And this is in no way means to be the end of it, but at least we thought it was a reasonable approach to encounter patients with cardiac troponin increases. And what we thought is, if you have cardiac troponin increases above the 99th percentile, this is a marker of self-death, as I've shown before, except for certain a few exceptions. And it is in the presence of overt ischemia or the absence of it that then you will make your clinical decisions. If you just have a cardiac troponin increase, a marker of self-death, but the clinical picture by no way is screaming that there's overt objective myocardial ischemia by symptoms, ECGs, or imaging, then by all means, this is not infarction. This is cardiac injury. Whether this is chronic or acute depends on the clinical circumstances, but I think we see a number of these patients that have cardiac injury, such as myocarditis, chronic heart failure, critically ill. And I think at least in US practice where troponin is used widely, we see a bunch of these patients. It is when you have overt ischemia, clear definite symptoms, coupled with objective data of ischemia, such as ECG changes, regional wall motion abnormalities, a thrombus and coronary angiography, that then you're going to say, indeed, we're going to call this the clinical syndrome of myocardial infarction. And there you're still faced with the task of differentiating whether this is atherothrombosis in origin or due to a supply-demand mismatch in the absence of atherothrombosis. And the reason this has therapeutic implications is because, as you may very well know, most of our guidelines, both NSTEMI and STEMI, the vast amount of 90% of those large documents, therapies are truly triggered towards plaque rupture. And that is a therapeutic implication of that. With that, I want to switch to the other aspect that I feel the universal definition of myocardial infarction helped in a way push the field forward, which was how we approach diagnostics, how we define the abnormal thresholds, and how we approach the rule-in and rule-out strategies, something that I discussed last year, but I think there's been some recent updates, but more importantly, just to emphasize again, something that I think will be very timely to understand, particularly because high sensitivity assays were just FDA cleared for clinical use in the United States this January, the first manufacturer. So we've been talking about this assays coming to the United States for a long time. Finally, the first one was approved this January, and hospitals will be transitioning throughout it in the United States. And I think there's much confusion about what a high sensitivity assay is, and you see somewhat of many reactions to this. But the reality is that this is an analytical definition. It's not. We're not talking about diagnostic sensitivity. We're talking about analytical sensitivity. So contemporary assays, they measure troponin. They provide a measurable value. The laboratory will give you value. In normal people, because this is how they do the studies to try to provide definitions of what is a point of care assay, what is a contemporary assay, what's a high sensitivity assay, in less than 50%. So for example, if you think about Abbott Northwestern or Hennepin, we use the same assay at both hospitals. We use the Abbott Architect Cardiac Troponin I. It is a contemporary assay, and if we take normal people that are not having any clinical condition, it should provide a measurable value in less than 50% of individuals. So what is the difference with high sensitivity assay? The difference with high sensitivity assay is that it is now able to measure troponin in over 50% of healthy individuals with a very high precision. This is the coefficient of variation, which essentially is a factor of precision. And the reason that is important is because the current assays that we have more analytical noise. So you can see more false positives that are just to the test being lousy, in other words. In order for you to understand how there was industry push and a manufacturer development towards high sensitivity assay was partly because of the push towards improved precision. So at the time, the 99th percentile was promoted as the threshold to define myocardial infarction. What you need to embrace is that at that time in the early 2000s, that threshold of the 99th percentile, most troponin assays didn't have sufficient precision at that threshold. So in order to provide an improved test, the leaders in the field said, we want at least 10% precision around that cutoff. And that is what ultimately pushed manufacturers towards developing more sensitive, analytically sensitive assays. And the implications of this are a couple. One, as I said, is on precision. There's one of the studies we did that I think nicely illustrates the impact of analytical noise. So this is actually the same assay we use here at Abbott Northwestern. This is the Abbott Architect Cardiac Troponin I, as shown in green in 2 individuals. And let's pretend this patient has some potential symptoms of ischemia, has serial cardiac troponin measurements, and as you know, the threshold we have, it's around 0.03. Here is in nanograms per liter, but it's the same cutoff. And essentially, you would think to yourself, oh, there's a rise and or fall. There's a pattern of cardiac injury. Maybe I need to take some action. Maybe I need to search some aspirin, heparin, call cardiology, and so on, right? I think that it's very reasonable. However, when you use a test with more precision, the high sensitivity, then again, there's been some degree of concern that this will have more positive. it has much better precision. So this is the same samples measured, and now you see that the measurements are flat. They never went up. So what we were seeing was analytical noise. So that is one of the reasons these tests have been promoted to be implemented in clinical practice. I think this is shown now here in a table format. There's numerous manufacturers. This is just some that I have decided to show here. And this is the analytical changes that you'll see. If you think about the one we use right now at Abbott Northwestern, which is the Abbott Architect, it only measures 2% of normals. If you were to transition hypothetically to the high sensitivity format, it measures now normals 96%. But you also have to understand, which is not the purpose of this talk, I believe I talked about this last year, is that this ability to now measure with precision these very low concentrations has opened a lot of new opportunities. And these opportunities are now being examined in ways to assess cardiac toxicity in patients that have, for example, breast cancer that are being started on therapies. This is being now even tested for primary prevention. For example, rather than getting a calcium score, you can just get a high sensitivity measurement and try to re-stratify whether you need to intensify or not your step-in treatment. This is all yet very early stages, but the ability to do this has opened and led to a number of studies that have been now actually published in JACC and New England Journal of Medicine. They're not yet part of our routine clinical practice, but that is sort of where the field is moving now, that we're able to precisely measure at very low concentrations. And the other aspect that I said is precision. If you think about the precision that the manufacturer tells us that our current assay has, it's around 14%. The one that that if you were to adopt the Abbott Architect, that would be around 6%. And this is a fact for all assays. By no means I intend to, promote neither of these, but it's just better precision each time you go to a high sensitivity format, because that is what defines 10%. You may wonder, well, what's the purpose of this in the context of myocardial infarction? Well, the purpose is that if you have patients with symptoms suggestive of myocardial ischemia, our current approaches, as you may very know, are a bit painful. Patients come to the ED with chest pain, and if they don't have facial elevation, they have to have measurements for 0, 3, 6, 9, 12, go to the observation unit, get cardiac monitoring, they get admitted. They're likely staying overnight. Whenever we get to round them in the morning, maybe they'll go home. So it's over 12 hours or so. It takes time, unless we do other approaches, or just a CT or others. What this has challenged, what the ability to measure this measurement at low concentrations has provided, is that now within a couple of hours, we can quickly identify patients who are at very low risk that you can discharge home. And this is probably the wide number of papers that you have seen probably over the past 3 to 5 years, mostly European or from the Asian Pacific region. We actually summarized the strategies last year in the American Journal of Medicine, but there are 4 strategies that have come about. The first one is the use of undetectable levels. So this is not the 99%, so this is the limit of detection. We actually just published a couple months ago, it's in press right now, one approach. This is US data from the emergency department at Hennepin, and if you just get a single troponin, a single measurement, and that is undetectable, in other words, below that limit of detection, around 27% of patients, you would be able to right away risk stratify them as extremely low risk for 30-day myocardial death and having myocardial infarction. It's very hard to get an NPV of 99.6 and sensitivity of 98.8. If for whatever reason this is not as good for you, if you combine this with any non-ischemic ECG, you're going to now be approaching 99.5 and just miss like a couple of events. This is a great tool. Some of the concerns of this approach is in early presenters. If you just had chest pain 15 minutes ago and came to the ED, there are some limitations to these strategies in which you would still have to be at least a couple of measurements. But again, not the 4 or 5 that we sometimes do right now in contemporary practice. The other approach has been to combine measurements with a risk score to evaluate patients with suspected myocardial ischemia. So what folks have done is they do either one measurement or a couple of measurements. They combine it with some sort of risk score, such as TIMI. And if all of these are low, they would also come to identify the patients are at very low risk and also rule them out right away. an approach that has been gaining quite a bit of momentum, and it's actually used widely in Scotland and in some areas of not only Scotland but in the UK, is that the use of a single measurement that it's not based on analytical thresholds. So this is an analytical threshold. This uses some analytical thresholds. This uses analytical thresholds. The investigators in the UK were actually able to collaborate with them in this Lancet publication as the validation cohort, is that rather than thinking about the upper reference limit or the limit of detection, they made a very nice question, which was, let's forget about thresholds. Is there just a concentration, the highest it can be, that would allow the acceptable MPV that would rule out the most majority of patients as possible? And what they came to identify is that a concentration is less than 5 nanograms per liter would identify over 2/3 of patients in the emergency department who had no cardiac troponin increases, in which the MPV was 99.6. This is quite impressive, and that's the reason in Scotland they did the derivation and validation cohorts, which we're a part of, and this is now part of routine practice of what they do over there. And lastly, accelerated serial sampling, which is probably the one that has the most data behind it, which is 0 and 1 hours or 0 and 2 and 3 hours. And again, I want you to contrast that with what we do in clinical care today, which is 0, 3, 6, 9 in prolonged care. So there's been a number of studies that they just obtain a couple of measurements. And again, keep in mind that this is only possible because now we're able to measure very low concentrations with high precision. And if you're able to obtain a couple of measurements within the first 3 hours and they have no significant changes, you're going to be able to rule out patients for myocardial infarction with a very high negative predictive value. And it is for that reason, I think in many things, you know, we are somehow behind to the European practice since 2011. The European guidelines have provided a 0 and 3 hour recommendation, class 1 recommendation, that with a couple of samples, within hours, you're done, going home, if those are negative. They push it further in 2015 AC guidelines to say that with a couple of measurements, 0 and 1 hours, you can go home. However, I do not mean to advocate for that, as there's been many concerns and many letters by many experts in regards to the 0 and 1, because there's some concerns about its performance, particularly in those that present early. But just to illustrate that in comparison to US practice, that again, as I said, implicates millions of dollars in costs and length of stays, is that you know, there are approaches available that within 3 hours or so you can rule out patients. So as I said, FDA clearance of high sensitivity assays at least one manufacturer earlier this year. So this is no longer a hypothetical theoretical talk, but it's reality. What will happen now that you'll get patients referred, or you will start using high sensitivity assays in the very near future? What will happen upon implementation? As you may very well have seen, read in magazines, journals, or news, there has been this long concern that adopting these assays will be somehow related to epidemic of cardiac injury and infarction. But is that the fact? We actually looked at this. And what you have to embrace, I think, is that it all depends about the point at where you start. If you have a very insensitive old assay, if you're using CKMB, which of note has class 3 recommendations in the latest NSTEM guidelines, if you're using CKMB or an older troponin assay, and you adopt a high sensitivity, by all means, you will see more events. However, what you need to embrace and understand is that the assays we use in practice, like the one you use here at Abbott Northwestern and the one you use at Hennepin, they're already pretty good contemporary assays. So this is data using actually the same assay that you use here at Abbott, which is the Abbott Architect. And if you look at data, which would be similar if it were tested here, around 30% or so of the patients have positive value. 43% have completely undetectable measurements, and 29% have a measurable value that is within normal range, but is not technically abnormal because it's not above the upper reference limit. We tested this in over 7,000 samples. So what happens when you move to high sensitivity? So there's actually not an increase. It's the same. There's not a marked increase in cardiac troponins above the 99th percentile. So really important to emphasize that the adoption of this high sensitivity assays that have superior precision does not necessarily translate to this so-called epidemic of injury and infarction that many have feared, but rather the analytical sensitivity is seen in the shift of those very low concentrations. And now you can see from 43% being undetectable, now it is 56% that are detectable. And as I said, this has implications in how we now are able to perform those very quick, rapid rule-in, rule-out protocols within 3 hours, as has potential implications that are being tested in prevention, assessing of toxicity, and so on. Similar, if you're not thinking just about the positivity rate of a test for myocardial infarction, we looked at this a couple of years ago, and by the same token, there's not a marked increase in the number of events that are being adjudicated as myocardial infarction. Something that you will have to embrace and understand as well as we prepare for this transition and adoption to high sensitivity assays is that we will pass forward from using micrograms per liter and using this 0.001 or so on to whole numbers, 16, 34, so on. This is an issue of safety. There are mistakes, there can be mistakes in the laboratory when you're saying 0.02, you have a mistake in your dot, and now there's an abnormal troponin. So there's a shift towards whole numbers. Therefore, the units will change. And the other thing that I wanted to focus primarily on myocardial infarction, but this is a reason I wanted to give this update, is that there are a number of studies that have shown that men and women are different. We have different amount of myocardial mass, and that therefore, using the same cutoff for both men and women, it's not right. So for high sensitivity assays, you will see that now the report will be sex specific. So men, for example, if you think about this assay, the threshold is 34 and women is 16. And there's some studies that have suggested by using this approach, we may potentially overcome the underdiagnosis of myocardial infarction in women, because until now, we've used the same threshold for both men and women. So there's clearly a paradigm shift in the approach to how cardiac troponin is used to evaluate patients with myocardial infarction. We summarized this a couple of years ago in the American Journal of Medicine, and just here we came with a position from the International Federation of Clinical Chemistry in collaboration with Fred Apple and Alan Jaffe that really summarizes all of these things. And what I want you to provide for those of you that were here at the beginning when I talked a little bit of the history of myocardial infarction is that we may pretend right now that we know all the details of myocardial infarction, but I think it's really humbling to think about perspective. The first report, as I mentioned at the beginning, of coronary thrombosis in the literature was in 1878, 139 years ago. And from then, just in 139 years, we've moved forward to balloons, stents, IVUS, OCT, CT, and others. It's amazing what has been accomplished. By no means should we pretend to have all the answers, but rather think that there's many opportunities moving forward in an understanding of the mechanisms of heart disease. By the same token, I wanted to show the report that I showed at the beginning of the first episode of coronary thrombosis reported in the literature, which was that of coronary thrombosis by Adam Hammer, the German physician that I said encountered a patient that he proved on pathologic examination to have coronary thrombosis. But what's interesting in a way is that when you go back to the report, and actually Fine Circulation mentioned this in 1985, is that was even though this patient had coronary thrombosis, it was not due to atherosclerotic heart disease. It was valve vegetation with a thrombus that had obstructed the coronary artery. So how cynical that how our understanding of coronary thrombosis, atherosclerosis, and myocardial infarction, it indeed started with what we call today type 2 myocardial infarction. So with that, some of the take-home points that I have today is that I really think, at least from our perspective of being cardiologists, the ones that are taking the consults are being asked to be the experts of interpreting the tests, I would highly suggest and promote that we use the right nomenclature. It's not troponin, it's not troponinitis, it's not troponin leaks. We should refer these patients as having myocardial injury. It has a prognostic significance, and avoid use of terms that diminish the importance of these events. 2, myocardial injury and type 2 myocardial infarction, particularly in the United States, where we use this test in a broad fashion in unselected patients, represent the majority of cardiac troponin increases, and they're associated with worse outcomes as I've shown. 3, I think it's important to emphasize that implementing these assays will not necessarily equate to an epidemic of cardiac injury, as has been promoted in the news. And fourth, that high sensitivity assays, as I should have the potential to allow the rapid rule out of acute myocardial infarction and provide a more precise test at very low concentrations. So that's what I have for today. Thank you very much.
Questions?
Hi, Yader, fantastic, absolutely fantastic.
Thank you, Chris.
Do you have this available at Hennepin's ER right now, or is it only on protocol, the high sensitivity troponin?
Yep, so they were just FDA cleared, just one manufacturer. Their Roche diagnostic assay was FDA cleared this January. Best to my understanding, I was asking some of the experts actually yesterday, it's uncertain to me that no one has yet implemented it yet in clinical practice, but it's going to happen at any point this year. All the data that we've been able to do has been on an investigational fashion. And now that this first assay by one of the manufacturers was cleared by the FDA, it is expected that it will open the gates for all the other manufacturers that are used worldwide to be now implemented.
The negative predictive value of 1% or less is the 1% miss rate is the goal for all imaging. And so you'll already have achieved that from this. It's fantastic.
Yep. And I think, just to echo this, this is one way to tease out patients that have, if they have undetectable concentrations, the NPV is very high. But as I showed, that's only like a third of patients. There's still a huge proportion of patients that will have a measurable concentration, that there you would now need other things like CT, and then you would have your answer. So by no means it intends to replace other modalities, but to answer a question for some patients.
So is it known if you have does a cell have to die to release troponin, or can it just have a membrane leak and still recover?
I think, so let me come back to this slide. This is the reason I find this particular study fascinating, and maybe I'll just briefly, since some people might have showed afterwards. This was just published in JACC, actually a few weeks ago, which was timely for this presentation and answers your question. There's a porcine model. They performed 10 minutes of brief ischemia by putting a balloon up in the LAD, and then they measured serial cardiac troponin measurements, and then they sacrifice the animal and do a pathologic examination to identify how the heart looks, and do some fancy models to test whether there's necrosis and what's happening. What's fascinating about the study is by just performing brief ischemia for 10 minutes, there's a marked increase in cardiac troponin. However, on pathologic examination, there was no necrosis, but rather the main mechanism was apoptosis. And that is one of the reasons that the term that's being pushed to referring to this cardiac troponin increases is injury, which I think correlates well to what we see in practice, that it is not necessarily necrosis what we're seeing in all of these patients, but rather some degree of injury. And so the mechanisms are various. As I think I show at some point here, it can be either to necrosis, apoptosis, autophagy-associated cell death. From a clinical aspect, when we're seeing patients with a troponin increase, I think we can't say which one is the one that predominates, to be honest.
But doesn't apoptosis, doesn't that imply that that particular cell died?
Correct, but not necrosis. So it's myocardial cell death, and that's actually the reason in the algorithm that we came to develop to how clinically approach this should be used. We refer to myocardial cell death, not necessarily necrosis. So it is cell death that can have different mechanisms. So yes, it's a mechanism of cell death, but I think either myself and many others would sometimes say like, oh, there's a little bit of myonecrosis, but in reality, there's various mechanisms.
You know, I think Chuck's question is spot on, and I disagree strongly, as you know, with the term type 2 myocardial infarction, because I don't think you have any pathologic evidence that cell death is occurring. And as you know, if you go out and work out at Lifetime Fitness for 30 minutes in the morning, your troponin is going to go up. So there should be a lot of us in this audience who have no myocardial cells left because they're all apoptotic or whatever the mechanism. So I think the term type 2 myocardial infarction lacks a pathologic correlate, and until we have proof that that's actually what's going on, it's a poor use of the term. And so in terms of what we see right now, the high sensitivity troponin introduction doesn't worry me. It's how we use troponin in general that worries me, whether it's the current assay or the new one. And that has to be considered right now, because we're going to bankrupt the healthcare system if we don't address the issue in a meaningful way, as you have outlined. It was a great talk.
And I think that's a fear that some have had, which I think it's fair to have. I think that's the reason I actually showed this slide, because to me, it's hard to do some of those basic science, very neat pathologic studies early on that we had with coronary thrombosis. But if you look, for example, at this study from JAMA 1939, this was pathologic examination of patients that had overt clinical syndrome of myocardial infarction. When they looked at the heart on pathologic examination, they were looking at the actual heart. They were indistinguishable from those that had coronary thrombosis. And the etiologies were those that we call type 2 myocardial infarction, had severe anemia, malignant hypertension, aortic stenosis, and so on. While I agree that even the right, correct. But even if we do not agree with nomenclature, the point is that it's not about what we call them. I think it's ultimately the clinical significance of its prognosis, and that there is, as you pointed out, which I completely agree, that if we do not embrace how to categorize these events, how to measure troponin, as you said, in the United States, when you talk to folks across the Atlantic, troponin is used very differently. They are using it in patients that come with chest pain to the emergency departments, whereas the practice here in the United States for A or B, liability, and fears of missing MI, it is much wide, as we all know. If you have nausea, vomiting, or weakness, you come with a nursing home without documentation, you get a troponin measurement. So without a doubt, there are concerns in what the potential implications are. However, I think in some regard, at least for hospitals like Abbott or Hennepin that are already using sensitive assays, I think there's some of that degree of concern that we will have a lot more events does have to somewhat diminish, because as I've shown here, there will not be marked increase in positivity rates. So I think these concerns apply more to hospitals that are using less sensitive assays. So if you're a hospital that you're using a very old troponin assay or a CKMB, and you adopt high sensitivity, by all means, be concerned, because you'll see more events, and may potentially that will translate to more cost. But if you're using a pretty good assay as you are here, at least from what we have tested, you should not see a dramatic epidemic of positive results.
So, great talk, but to echo what has already been said, I can see how this high sensitivity assay can be very helpful when it's negative. To count, if you want to make it cost effective, the 2/3 should be also managed in a cost effective way, and we should probably change the way we think about a positive troponin, not only kind of be happy that 1/3 is negative. In my mind, many times now, when the troponin is positive, that triggers a transfer that's called MI, and that triggers potentially an angiogram. And we also probably should change the way we allocate resources. So we should now have probably a CT angiogram on call for level 1 for acute MI. But you know what I mean? Now, a positive troponin might not mean that they need to go to the cath lab. Maybe instead of waiting for 48 hours, waiting for a cath lab, they need a CT angiogram within 2 hours if the trend is not going up. So it requires a lot of training to be cost effective for the 2/3 that will have a positive reading.
I completely agree, and I think the way at least I see it, and I think this slide echoes this, to me this is not a problem of the assay. To me that's a problem about our culture of how we approach testing, which to be honest, it's not a matter of troponin. I think we see this overutilization of tests with many tests, not just exclusively troponin, because of fear of missing MI, liability, and so on. But there's practice culture challenges. And that's the reason many people have emphasized, not only with high sensitivity, but even with how we use the test right now, that education is required. And to be honest, even though we're talking about this here in cardiology grand rounds, I applaud emergency physicians worldwide in the United States who are tackling this issue and doing a lot of education in how to use the test wisely, because I think more and more they're embracing that in order to use this well and reduce overcrowding, which is their ultimately purpose, not to admit everybody, they need to use it more wisely.
Yeah, outstanding job, Yader. I think, Scott, everybody appreciates the point, and hopefully, people will be looking at this in people who present with chest discomfort as opposed to oh, this person is just sick, let's check a test,
Right.
Type of thing. The other question is, what are the prognostic implications of being below the level of detection and above the level of detection versus the 99th percentile? And does that trigger a different workup? Does being less than 99%, less than the level of detection, does that mean that person doesn't need a stress test? Or, you still have to take the clinical scenario into account. So the problem is going to be if you draw these arbitrary distinctions below the level of detection, then in between that and 99%, who gets which test when? And that's going to be the devil.
I completely agree. There's two, for the purpose of time, I did not include additional slide that actually had that answers your question perfectly, but two answers for that question. One is if you look at injury, which as of now it's defined as the 99th percentile, which as you completely said, it's an arbitrary analytical threshold. Certainly compared to those that have a value below, outcomes are much different. That has been shown. This is not even taking into account anything else, whether you have ECG abnormalities or anything. This is just a troponin increase. It clearly has a prognostic significance. What I did not show, and answer your question, is that people have looked at the prognostic significance of even a measurable troponin within that normal range, and it definitely has. In that Lancet publication from the UK of over like 6,000 patients, this was there's a very nice curve, Kaplan-Meier, in those that have any detectable concentration, and the higher it is, the more events you have. So by all means, it has prognostic significance, and that's the reason outside of the acute setting, people are trying to use this for primary prevention risk stratification approaches to try to say you come to clinic, you have a detectable concentration above the limit of detection, maybe we should consider implementing other things like aspirins or statins. So it has opportunities, it has challenges, as some have mentioned.
Any other questions? Okay, thank you. And please do complete a survey or an evaluation for us. Thanks. Have a great summer.
We have to bring you back wherever you are. Yeah.